Assalamu alaikum warahmatullahi wabarakatuh. So this is the first station in the new module, which is the oncology module. I know most of us can struggle in this module while it's very straightforward, and if we know the concept of the history taking in case of oncology patient and how to manage it, then it will be very easy to you. So in the exam, most probably you will have one station from the oncology module, and they are almost similar to each other. So I myself consider this station is a guaranteed station as well. Okay. So I will tell you the important points in the history and how to counsel a patient while we are talking about the station today. So you are currently working as a specialist trainee in a tertiary center gynae oncology unit and about to see Jane Goldman Sachs. She was seen in your consultant's last colposcopy clinic under the 2 weeks wait referral system. A routine smear was noted to have a suspicious warty growth on her cervix. At colposcopy, this appeared to be an obvious cervical carcinoma. It appeared to be macroscopically limited to the cervix and to be 2 cm in size. Punch biopsy has confirmed it to be a squamous cell carcinoma of the cervix. The patient is here to have her test result and to discuss what will happen from this point. So it's just a Breaking Bad news station, but before that, we need to take the history. So first of all, you introduce yourself to the patient by name and role. Then you tell her, you ask her about her name, date of birth, and confirm the aim of the meeting that she is here today because she wants to know about her biopsy result. Then you tell her, I have your result with me, and I will tell you the result in a moment. But before that, can I ask you a few questions to know more about you, as this is the first time to meet you today? Yeah. So, what are the important points in the history you need to ask for this patient? First of all, if any complaints at all. Okay, can you tell me more about what happened exactly? She was during her routine smear, so most probably this patient doesn't have any symptoms, and just she had a screening test and it revealed these things. But some patients may have symptoms, but they didn't realize that it is related to it. So ask about if she has any symptoms, what happened exactly, and then go straightforward to the gynecological history. You need to ask about her menstrual cycle. Is it regular or no? And is there any intermenstrual bleedings? And what about if she's sexually active? What about the intercourse? Is there any postcoital bleeding or no? Okay? And ask about the risk factors. If she's having any or if she has been diagnosed before with any sexually transmitted infection. What are the kind of sexually transmitted infection that we are asking about? As all of you know that almost all of the cervical cancers are caused mainly by human papillomavirus. So clearly we need to ask the patient if she was diagnosed or if she has been diagnosed before with human papillomavirus or not. The other sexually transmitted infection, which is very important here and can predispose to cancer cervix indirectly, is HIV. We can't ask the patient, do you have HIV or no? But if she denies that she has any sexually transmitted infection, then that's fine. And you know all how the HIV can cause cancer cervix. It reduces the immunity of the patient, and making the HIV more virulent and can attack the cervix easy. Okay, so it's like an indirect thing. On the same time, we need to ask about the contraception. Okay, the oral contraceptive pills, which are combined oral contraceptive pills, are risky to the cervix. So if the patient is using hormonal combined oral contraceptive pills for at least 5 years or more, she will be at high risk for having cancer cervix. So we need to ask her what kind of contraception are you taking and for how long. Ask her if she's up to date with her cervical screening. Sometimes a patient may be invited, but she will not go at the time of invitation and skip one smear test. So we need to confirm if she is up to date or not. Okay? The most important question, if she is with her regular partner or any other partners, and for how long she has been with this partner. Okay? And finishing the gynae history, we need to skip to the obstetric history. What is the importance of obstetric history in case of cancer cervix? Do you know that the high parity is a very high risk factor for the cancer cervix? Because you know the delivery of vaginal birth is just a dilatation to the cervix, and it is considered as a kind of trauma to the cervix. So, do you know the theory of repeated same trauma to the same tissue can predispose for cancer by the theory of chronic irritation? So, it is the same idea. So, high parity, which means high injury or trauma to the cervix many times, this will predispose for cancer cervix. So, I don't need to know details about the pregnancies or deliveries or anything like that. I just need to know how many times she got pregnant, how many times she delivered. Okay? And as any cancer patient, don't please forget to ask about the general symptoms of having a cancer and the local symptoms of having a cancer. Very important. General symptoms in terms of easy fatigability, loss of weight, feeling unwell, okay? And local symptoms, cancer cervix, what do you think? So cancer cervix can have mainly pressure symptoms rather than having anything else. Before it can spread, it will press on the surrounding. Mainly it will affect to the first extent the kidneys. So it may press on the ureter bilaterally, causing pyelonephritis or even renal failure. Okay? And sometimes it may compress on the bowel itself. Okay? And sometimes the patient may have compression to the extent that it may close the neck of the womb opening, and she may have a hematometra. So chronic pain, pressure symptoms, frequency of micturition, frequency of defecation, and loin pain. Okay, we need to run some investigations on her, like renal function tests and urine dipstick. Okay, sometimes the cancer is originating from the uterus and coming to the cervix, so I need to know whether she has a regular period or no, as I told you in the history. So very important to ask about the symptoms of the tumor generally and locally. Okay, then coming to the other parts of the history, as any patient as usual, so you need to ask her about any other medical problems, any allergies, Very important to ask about family history of cancer. Don't forget. And while you are coming down to the remaining parts of the history, don't forget to ask about smoking because it's a risk factor as well. So try to manage to include all the risk factors in your history. Okay? Okay. So, how to break the bad news? We all learned that before in the maternal medicine module, but we need to repeat again because it's long time. We have been there. So, first of all, you need to signpost and confirm that she's able to receive the news. So you ask her, Jane, I can see you are alone today. Do you want to call anyone from outside to be with you? She will ask you, why, doctor? Then you tell her, because I'm going to give you a lot of information, and if you need someone to support you during that time, that's fine. If you are okay to have the news, she will tell you, I'm okay, just tell me the information or tell me the result. So again, you have to signpost and tell, I'm sorry, I don't have a good news for you. You need to tell this sentences like that. I'm sorry, Jane, I don't have a good news for you. And you have to stop to pay to let her to pay attention to you. Okay? And stop like few seconds and then you tell her, unfortunately, the biopsy showed that you have a squamous cell carcinoma of the cervix, or you can just tell her the biopsy has confirmed that you have a cancer in the neck of the womb. Okay, and please stop here. Let her make her own drama. Don't talk at all during her crying. You just be sympathetic and show empathy and give her tissue, give her water, and wait for her to finish. And her reaction may be over because she's young and you tell her that she has a cancer, so she will just reply to you, I'm going to die, I'm going to die, how many days I will live, like that. Okay, so our rule here is to calm her down, to reassure her, and then apologize again for the news. I'm really sorry to be the bearer of that bad news. I know how stressful situation you are in, but I'm here to support you. I need to reassure you that your cancer is still very small in early stage and very limited to the cervix. And we have seen many cases like you who have been cured completely without need for any further treatment rather than the primary treatment. We are here to help you, to give you the optimum treatment that will help you to overcome this and cure you completely. Okay, then she will start to calm down. And if she didn't calm down, you can ask her, is it okay to talk about it now, or do you want me to arrange another appointment for that, because I need you to be fully aware of everything. Then she will tell you, no doctor, you can please continue, I want to know now. Okay. In case of cancer cervix or cancer ovary or cancer endometrium, any cancer ever, if the patient is young, what we need to do? Very, very, very important question in the history. I forgot to tell you during the history, which is, what is your plans for future fertility? Okay? Why? Because most of the cancers we face, we need to remove everything. What if the patient doesn't have children? What if the patient's planning to have more children? What we need to do? So we need to prepare ourselves for alternative treatment for the patient who is wishing for future fertility. So in this case, when we are going to speak about the treatment, First of all, if you feel that the patient is totally distressed and she can't cope, you can offer for her counselor, like the maternal medicine counselor, support group. You offer her help from the team. There is a specialist nurse will be with you, will support you, like that. Okay. And if you want to arrange another appointment, you can come, give her your contact details, everything like the maternal medicine. But I'm specifically want you to know about the treatment option for this patient. So, what is the best option of the treatment for cancer cervix? Whatever the stage, is to remove everything, to do total abdominal hysterectomy, bilateral salpingo-oophorectomy, right? And this if the patient has completed her family or if she has an advanced tumor. Actually, our patient is not having an advanced tumor, but she may not be having completed her family, so we need to try to search for another option. Okay? But before we search for options, we need to tell her that we need to confirm the staging of your cancer and confirm it is limited to the neck of the womb, not spreading anywhere else, not pressing on any other organ. And then we will do some, to know that, we will do some more scans, more investigations to know your case in a proper way and stage you. And then we'll send your notes to be discussed in multidisciplinary team meeting, which is conducted by a group of consultants from different specialties. They will see your results and then they will decide your best option of treatment, taking in their considerations your fertility wishes. You will be given an appointment after this meeting held to know what are the outcome of this meeting, what is the best option for your treatment. If you are happy for the treatment decided by the MDT team, we'll go ahead. If you are wishing to change it and to have another plan of treatment, that's your right, but you have to know that the risk of spreading, the risk of recurrence may be higher if you choose another option. Okay? So that's how we counsel her. So what are the options available for her? As I told you, if any patient with cancer cervix, we need to remove everything. And we need to remove everything either by simple hysterectomy or radical hysterectomy. What is the difference? Simple hysterectomy is to remove the womb, neck of the womb, tubes, ovaries. You have to explain to the patient. Radical hysterectomy is to remove the womb, the neck of the womb, tubes, and ovaries, and to clear the lymph nodes from the pelvis. And for your knowledge, it may be up to the para-aortic lymph nodes. And to decide which one you need, we need to know whether your cancer is spreading to any of the lymph nodes or no. Okay? So if it is involving some lymph nodes, we need to do the radical hysterectomy. And if you have done or if you undergo this kind of surgery, you may expect some heaviness in your legs after the surgery because of the failure of the fluid to be collected by the lymphatic system, what we called edema. Okay? And in this situation, if the MDT has decided that the best treatment option for you is to remove your womb or your cancer is spreading or pressing on anything else, and we need to remove your womb, ovaries, and cervix, we may need to refer you to the fertility center to have your eggs or embryos freezed, so that after you remove everything, you can use them in a surrogate mother. And this baby may be genetically related to you, will be genetically related to you. Or if the MDT has agreed that we may leave you to have a baby with your own womb, in this situation, we may need to remove the neck of the womb completely. And this operation is called trachelectomy, in which we will remove the neck of the womb and part of the vagina as well. Okay? So when we remove a part of the vagina, you will have a short vagina, and you may have some dyspareunia after that, so a difficult intercourse or painful intercourse. And also, if you have trachelectomy, you will not be able to deliver your baby vaginally if you get pregnant, because there is no neck of the womb. Okay? And since we have removed the neck of the womb completely, there is no more need for cervical screening, so no more smear test to be done. And sometimes it may be the final treatment and you don't need any further treatment, on condition that on the follow-up visits you will not be discovered to have any recurrence for at least 5 years. So we need to arrange a follow-up plan for you if you have trachelectomy for 5 years to be sure there is no more cancer cells, and then there is no need for further treatment. Some patients may not prefer surgery or unfit for surgery. So we have another option of treatment called radiotherapy. But radiotherapy is just radiation, and it has its own risks. You will avoid the risk of surgery, but you will have the risks which is coming from the radiotherapy. The radiotherapy is just a radiation conducted locally and directed to the cancer cells. We have to do it either from external device, putting it on your tummy from outside, and this has to deliver high radiation to your pelvis to kill the cancer cells. Or we can put an internal device from down below, which is called a vaginal implant, and this also can radiate the radiotherapy from inside to the cancer cells. Having this kind of radiation from outside, as you know, it will kill the cancer cells, but it will affect also the other nearby organs, because it's mainly radiation and it can affect healthy cells as well. Okay, what are the complications? What are the organs nearby the neck of the womb? You know, the bladder. Yeah, so the radiation can cause damage to the bladder. The radiation can cause damage to the bowel or interconnection in between each other. Okay, and can cause scarring tissue inside your tummy, and also it may affect your ovaries and causing premature ovarian failure, putting you into an early menopause. So if you choose this option, it's advisable to go to the fertility center first, freeze your eggs or embryos, and then start the radiotherapy. The other option is to have this delivered from the vagina to avoid these kinds of complication. Yes, it's a small device, it's releasing less potent radiation and it has less side effect and more near to the cancer cells, so it may be more specified, but also it can cause stricture to the vagina, making your sexual life not easy. But it's like less side effect than if you have it from outside. Usually, you may need to have 6 to 8 weeks of this radiotherapy if you choose this option, and these side effects may remain up to like 8 weeks after the treatment and then started to recover. In some situations, the patient may need to combine both treatments, like she will have surgery and radiotherapy as adjuvant treatment. And in certain situations, in the highly resistant cancer cells, we may need to add a chemotherapy as well. Okay, chemotherapy is just a medicine, and this medicine can affect the normal cells. Most important side effect of the chemotherapy is it makes you feeling unwell, easy fatigability, vomiting all the time, tummy pain, and also soreness in your mouth. Okay, and because it affects the blood cells, the 3 categories of the blood cells, so it can cause anemia, it can increase your risk of infection because of leukopenia, it can also increase your bleeding tendency because of the platelet count, and the main annoying side effect of chemotherapy is hair loss. And once you mention that to the patient, she will deny that she will try this kind of treatment. She has her friend who lost her hair and she doesn't want to be like her like that. So you can reassure her that in not all the kinds of chemotherapy are the same, not all have the same side effect, but even if you were exposed to a kind of a medication which may cause a hair fall, you may overcome this by either you cut your hair before starting treatment and donate it, you may cover your hair with a hat, or even you can wear a wig, okay, and reassure her that it's just a temporary thing and it's supposed to recover in 6 months after stopping the treatment. And we know that the treatment can harm the normal cells, but we are weighing the risks and benefits for your treatment and choosing the best option for you. And after having all this consultation, you have to put a 5 years follow-up plan after she has her treatment to ensure there is no more recurrence. So the 5 years follow-up plan can be applied for every cancer patient. We need to call her after she finished her treatment. We need to call her every 3 to 6 months in the first 2 years after treatment. And in the second 3 years after treatment, we need to call her every 6 to 12 months. Usually we do, if according to the tumor she has, mainly we need to do some scans, maybe tumor markers, if it is related to the tumor type, and screen her for any recurrence or anything. If nothing, we'll discharge her after 5 years to live as a normal patient. Okay, so that's it. I know a lot of information is given, but it will help us in the other stations. Thank you.